Good afternoon, everyone. I'd like to call the meeting to order. We don't have a quorum yet, though, so we're not actually officially calling it to order, but we're just a couple short. We'll get to that immediately, or as soon as we get enough members. But I just want to mention for anyone who's in the audience who's waiting for the medical marijuana bill that we are not starting that until 6 o'clock this evening. So if you're hanging around here for that bill, I would suggest go get some dinner before that hearing starts, because it might go late into the evening. Okay, but you don't need to be here right now for that. So with that, welcome to the committee, Representative Atkins. We can't move your bill officially yet. Oh, maybe we can now. I think we do. We do have a quorum. So,
Madam Chair, I'll move the bill. I'm not calling.
So, Representative Abler is moving that House File 1872 be re-referred to the Committee on Commerce. So, go ahead, Representative Atkins.
And thank you, Madam Chair. Did you get my author's amendment to legalize marijuana? Is that in the pack? I just thought, since that's what people are here for. No, I actually, Madam Chair and members, thank you for the opportunity to have this bill heard. I hope this is the beginning of a discussion about drug pricing in Minnesota. I'm going to keep my comments very short because I know that you've got a heavy agenda. So all I'd ask, Madam Chair, is I'll give a very brief introduction, then we'll have a walk through the bill and some experts. And at the very end, after the opponents, I'd just like a couple minutes to try to make certain that we address the concerns that they've raised. First off, I am not going to talk today about drug pricing per se, as much about the health issues. The pricing issues I expect will be in the Commerce Committee. As opposed to the health issues here. But what this bill does, it's about drug pricing transparency, and it's about patient choice. What we're going to have is Dr. Schondelmeyer and then some folks in the pharmacy industry talk about the impact that this has on people's quality of care, on their health, about keeping the local pharmacist involved. For my wife and I, over the last few months, between me tearing my Achilles and her having a cervical laminectomy on her neck, we've become a little bit of a prescription drug cabinet at our house with all of the various prescriptions. And if it wasn't for Greg Schoweiler, who's our local pharmacist, I'm certain that I would have done something to harm myself with all of the various options. Having his involvement, having his advice was critical to the recovery that both Julia and I had. With that, Madam Chair, I've got Ms. Lindu to walk through it, as well as Dr. Schondelmeyer.
And Representative Atkins, before we start with that, we do have a DE amendment, and did you want to have that? Are we going to be talking about the DE?
Madam Chair, we are. I just wanted to make sure that the mover of the bill would be comfortable with that. That is an author's amendment that would put it in the shape that we want to proceed.
So moved, Madam Chair.
All right. So Representative Abler moves the DE2-1 amendment. That's one we're talking about, correct? It's in your packets. And all those, we're going to put that on the bill so that the author can discuss it in the shape he'd like. So all in favor of that amendment, please say aye.
Aye.
All those opposed? Motion prevails. Okay. Go ahead. Welcome to the committee.
Madam Chair, members of the committee, my name is Jeff Lindu. I work with Thrifty White Pharmacies. We are a Minnesota-based, employee-owned company. Began in Minnesota in 1957, and I'm here on behalf of Thrifty White, and I'm also here representing the Minnesota Pharmacists Association. And I would just like to do a quick run-through of HF 1872. There are three basic sections of the bill. The first one deals with something that is called MAC, or maximum allowable cost. It deals basically with how PBMs price their reimbursement to pharmacies for generic medications. Today, about 75 to 80% of the prescriptions that are filled in a pharmacy are generics, and this has to do with transparency in that process. There's been a lot of talk that we're going to raise costs, that we're trying to somehow raise reimbursement for pharmacies. CMS has their posted fee schedules. Minnesota Medicaid has posted fee schedules. Minnesota Medicaid has a posted list of the MAC, or maximum allowable cost, the generic prices that they pay to pharmacies. They update that list very regularly. The list shows when each drug was the price was last updated. Transparency is apparently easy to do. Minnesota Medicaid is marvelously transparent. What we are asking is that the PBMs that we deal with for the largest portion of our business give us that same amount of transparency, that they let us know what the prices are that we will be paid on generics, and that we have a reasonable process to appeal those prices when it appears that they are not appropriate. The second section of the bill deals with mail order and specialty pharmacy. It is basically a request for any willing provider. If a pharmacy is willing to sign the contract that the PBM offers to a mail order pharmacy, or the contract that is offered to specialty pharmacy, if the pharmacy is willing to accept that rate, we would like to have it required that most plans refuse to allow us access to signing those contracts. Fragmentation of care is getting to be an issue for us. We simply want to keep our patients with us getting all of their medications from the same pharmacy, so that the pharmacist can provide overall care for the patient's medications. The last part is really data privacy. Two rather simple terms. One is if the PBM is going to sell data, and the sale of prescription claims data goes on all the time in the marketplace. It's not that that is wrong. It just simply requires that if the PBM is going to do that, they have to notify the plan sponsor who is responsible for those patients whose data is being sold. And secondly, a prohibition of having the PBM who is processing claims give patient-specific, prescription-specific information to a pharmacy which they own, which the pharmacy then turns around and uses that patient-specific information to market the pharmacy which the PBM owns. With that, I thank you for the opportunity to be here. I will say I urge you to vote yes on HF 1872, and I will turn it over to Dr. Schandelmeyer.
Thank you, Dr. Schandelmeyer. Welcome to the committee.
Thank you, Madam Chair and members of the committee. I'm pleased to be here today. I'm here as an individual. My professional role is I work at the University of Minnesota as a professor in pharmaceutical management and economics. I've studied this marketplace for 35 or 40 years, and I kind of know most every piece of the market and how it behaves.
And just excuse me one second. I just need you to say your whole name for the tape.
Yes, ma'am.
Thank you.
My name is Stephen W. Schandelmeyer, and again, I'm here as an individual, even though I work at the University of Minnesota. This bill is important because healthcare is critical, and the costs of healthcare, as you know, are a major concern to society. And sometimes things aren't always what they seem when it comes to healthcare and healthcare costs, and particularly pharmaceutical costs. Generic drugs account for over 3/4 of all the prescriptions in the marketplace today, and generics have helped hold down our costs in healthcare. And clearly the PBMs working with pharmacies have helped to increase that generic utilization. But one of the issues in this bill that's critical is these MAC prices, that the PBM does set a maximum amount they will pay pharmacies, and that's fine. They set a price in the marketplace. But what happens is that price is hidden. You're asking the pharmacist as a business person to sign a contract that says, I'll take whatever you're going to pay me, and you don't have to tell me up front, and I'll figure it out 30 days later, and then I'll figure out if I made any money at all or if I can stay in business. So first of all, it's just the hidden nature of these prices. But the hidden nature does a second thing. Not all, but many PBMs will turn around then, and they'll pay the pharmacy one lower rate. They may pay them $25, $30 for a given prescription. They'll turn around and bill the plan sponsor or the employer a higher price. They may bill them $40 or $45 or $50. And so there's this hidden markup going on that the plan sponsor doesn't know about, and when they're asked about the cost, oh, well, we paid the pharmacy, and here's, but they don't disclose what they paid the pharmacy to the plan sponsor. So there's what we call this max spread that can occur. There's actually a federal lawsuit against a major PBM for engaging in this practice under Medicare Part D, but it occurs in private plans, it occurs in the commercial market as well. And there have been cases of this occurring in Minnesota. So the concern is hidden prices allow markups and prices that other payers do not know about. And the employers, I help the university manage their drug benefit plan. And if this was going on in our plan, it would be very difficult for us to identify or discern. It could well be going on there as well as for other employers in Minnesota. So this, you will be told this will raise the prices, but actually this is about a place where PBMs make an extra margin that really isn't disclosed to anyone in the marketplace. I'm all for PBMs making a profit, for being paid for all of their services, but taking hidden margins out of the marketplace isn't what we need in healthcare today.
And Dr. Schandelmeier,
Yes.
if I could just stop you for a second, and you're the right person, I think, to give us this little bit of a background. I'm not sure all members, and probably all members of the audience, know what a PBM is. I don't think the title, the whole name has been given, and could you just give us 20 seconds on who we're talking about here?
Thank you, Madam Chairman. I forget about the details in these acronyms. PBM stands for Pharmacy Benefit Manager. Anyone in this room that has a drug insurance program, if you pulled out your card, there is probably a PBM, Pharmacy Benefit Manager, behind that card that processes the claims. They contract with the plan sponsor or employer, and then they turn around and contract with pharmacies and pay them. So they're sort of a middleman between your plan sponsor and the pharmacies. And again, they provide very valuable services, and they play an important role in our healthcare system, but they also play a shell game where there are sometimes hidden costs and margins that we don't see and don't track well.
Okay, thank you.
With that, I'd be open to any other questions, but I'll leave it with that. I encourage you to support this bill. It addresses a real problem that most people aren't aware of, and you'll be told this will cost you more money. It will not. It will save you money. There anywhere from 5 to 10, as much as 15% additional cost because of max spreads, these margins they add on to generic prices that often the end payer does not know.
Okay, thank you. I'm looking around. Are there questions at this point? Okay, I don't see any. This might be a good moment. There's also a technical amendment, Representative Atkins, and so I'm told by Mr. Chun this is just technical. It's in everybody's packets, the A1 amendment. Let's move that as well so that we don't forget. So I'm going to move the A1 amendment. Questions about that? All those in favor, please say aye. Aye. All opposed? Okay, good. Now we have the bill in the proper order. Thank you. Okay, and Representative Mack does have a question. Go ahead.
Thank you, Madam Chair. And this might be a question that could be split between the author and the prior testifier. But, you know, one thing that I don't think should escape members' attention is at the end of the bill, this bill excludes public programs, Minnesota Care Medical Assistance online. I'm not sure if I've got mine's on short paper, so I'm not exactly sure the line. But at the end, it states that. And I guess I'm wondering, maybe to the author, why are you leaving out public programs? And then maybe to the doctor, do you think that that's a good policy moving forward? Or if this is good for the private market, it should also go forward for government programs?
Representative Atkins?
And Madam Chair, Representative Mack, it might actually be more efficient if we start with Dr. Schandelmeier and then go to me.
Okay. Dr.
He'll be much more to the point than I would wrap around it. So.
Okay. Dr. Schandelmeier?
Actually, the medical assistance, Medicaid nationally, created maximum allowable costs as a payment mechanism to help hold down the cost of generics back in the 1970s. And Medicaid sets their own max, and they do disclose them. They are publicly available. You can find them on a website. They do disclose their method. Pharmacists know what they're going to get paid from Medicaid. So the public market is already doing this. The bill is simply asking that the commercial market catch up to what the public market is doing.
Representative Mack.
Thank you, Madam Chair. Well, then maybe to the author, why would it, if it's already being done, if all of the things spelled out in this bill, if I'm understanding you correctly, are already done by government public programs, is it necessary to be spelled out, or couldn't we just strike that language in the bill?
Representative Atkins.
Madam Chair, Representative Mack, I think that's a drafting issue. I think it was designed to express what is already taking place in the marketplace and not make sure that we weren't trying to extend this to someplace where it wasn't already occurring.
Okay. Okay, Madam.
All right.
Thank you, Madam. No, thank you, Madam Chair. Well, that's helpful, and I know this has more stops, so probably continue to ask that question, and just to get a better handle. My understanding was that this would possibly have a fiscal impact if it was applied to the state, and it sounds like you're maybe refuting that if this is already done, but maybe just something to follow up on and pay close attention to.
Okay, Representative Loeffler.
Thank you, Madam Chair, and Dr. Schellenmeyer. Since we're all learning how pharmacies work and drug pricing works, and a lot of comments have been made about transparency so that you understand who you're dealing with and what their prices are. I get that. But can you tell us a little bit about how this works for the ordinary insured person who doesn't have, or uninsured person? I mean, could be insured with a high deductible, so they're paying out of pocket, not through a PBM, or it could be an uninsured person who's purchasing. Does this have an impact on them? What's the transparency for that consumer?
Mr. Schandelmeyer.
Yes, thank you, Madam Chair, and thank you, Representative. I think if you're talking about the uninsured who would pay cash out of pocket, my experience, and there have been research studies that show that pharmacists will readily quote prices to anybody that walks in and asks, what's the price of this drug going to be? And if a patient has been to another pharmacy and found a lower price, and they go back to their regular pharmacy, usually that regular pharmacist, if they can at all do so, they'll match that price. So pharmacists are very transparent. I do believe that the state Medicaid program still has a site, they used to, that lists the prices that Medicaid is paying pharmacies. So a person can look up how much pharmacies are being reimbursed under Medicaid in the state of Minnesota right now. So there's transparency in that way. And then if they are covered by either one of these new health plans that are being offered through MNsure or through other programs, most of those health plans have a site where you can look up drug prices. Although I would caution that there have been even lawsuits under Medicare Part D and other programs where people look up on the website what the PBM says the price would be for a given prescription, and they find out that they're actually charged a different price later, usually higher. So there is transparency, but we need to be careful with that. But there's transparency in the private market for the cash pay customer if they just bother to ask the pharmacist.
Representative Loeffler.
Thank you, Madam Chair. I think I'm starting to get a feel for that. But the other question I had was, it seems like we have two different issues going here. One is sort of the pricing sort of thing, transparency, and the other that I didn't quite totally understand in the description of how the bill would work was the selling of the consumer's data to others. And could you just go through that a little bit slower, what it's being sold for? We oftentimes get into debates in this committee about data privacy related to patients, and I just want to make sure I understand what you're proposing to do here.
Okay, and just, we could do that really briefly, but I really would prefer, this is not going to be the last stop for the bill, and it is going to go to civil law, I'm sure, after commerce. Can't believe it wouldn't, so I'm sure that will be thoroughly vetted as well. But please, go ahead.
Thank you, Madam Chair and Representative. I'll try to be real brief. Pharmacists are concerned. They work with patients directly and care for them as an individual. And pharmacists are very concerned about the confidentiality of that data. In order to get paid, they have to submit the data to that pharmacy benefit manager. The pharmacy benefit managers turn around and aggregate that data, and they sell most of it in aggregate in a way that's de-identified. But sometimes that pharmacy benefit manager will either use that data to steer patients into another pharmacy that they either own or get payments from, or they will sell it to other parties that market directly to those patients knowing that you're on a diabetic drug or that you're on an epileptic drug. And so I, as a patient, and pharmacists in general as healthcare providers, don't want our patients being bombarded by marketing pitches that they did not solicit or authorize. And so that's what we're asking for in the rest of the bill.
Thank you.
Okay, thank you, Representative Loeffler. So I think we could probably go to our next testifier. Welcome to the committee.
Thank you very much, Madam Chairman and committee members. My name is Steve Simonson. I'm an active community pharmacist in Anoka, Minnesota. And I'd like to talk about and comment on this bill, how it positively affects patient care and patient choice. We've been taking care of patients since 1884 at our Anoka pharmacy, and the relationships we build over time with our patients is a critical part of delivering the best possible care to those patients. Patients seek out their pharmacist by name every day to help them manage their medications. The first step a new patient who comes into the pharmacy or with a new medication takes is the pharmacist to work with them to get buy-in so they'll be an active participant in their care. Doesn't matter how good the medication is, if it's the right medication or how it's prescribed. The patient doesn't think it's going to work for them and does not know how to take it. It really doesn't matter. So that patient buy-in and their active participation is critical, that you can only get when you're dealing with a pharmacist in the pharmacy when they're getting the medication. Patients who are forced to switch pharmacies are negatively impacted as they are from those potential positive outcomes. The positive patient-pharmacist relationship are severed with all of the benefits that come with that. Continuity is interrupted and their care is put on hold until they get their next prescription from wherever. Patients question their care, continue to ask questions of their pharmacist, and also ask, why can't we keep using you and the relationship we have, and participate in those plans under the same terms and for the same costs and prices? It happens every day. Patients, pharmacists have been proven to increase quality and keep costs down in study after study, with the patient being involved in their therapy. There was a recent report in the Minneapolis Tribune last week that patient-centered medical homes save money of about 8 to 9% on patient care. Many of those patient-centered medical homes have pharmacists involved, whether it's a pharmacist who's employed by them or a pharmacist who is working for a pharmacy associated with those clinics. It's a very positive relationship that is interrupted. The other part of the bill I'd like to address is data privacy. Patient privacy is also addressed in this bill. I believe it is reasonable to expect the plan sponsors are at least notified when the claims are used for sale and for the information they contain. Happens every day. Pharmaceutical manufacturers have been chastened and prevented from using that information to send out coupons and direct patients to their drugs in the past, but that information has value and it does get sold, and most of the time it's without the patient's or the plan sponsor's knowledge. Also, patient privacy is compromised when claims data is used to switch patients to mail order or switch patients from the patient's chosen pharmacy to the pharmacy of the plan's liking. Letters routinely show up in our pharmacy and are presented by patients asking us do we have to switch? How did they get my name and information? I don't want to switch to this company. The letters don't exactly say that. They're ambiguous, but because the patient and the pharmacist, the patient PBM and the pharmacy have a similar name, they assume that they have to switch pharmacies. I think it's not a fair competition for that to happen. So I urge your support for this bill. It's good for patients, and team-based collaborative care, which is Minnesota, is an example for the entire nation in that type of care.
All right.
Thank you.
Thank you very much for your testimony. I think we could go to the next testifier. Welcome to the committee.
Thank you.
Please introduce yourself for the record and go ahead.
Madam Chair and members of the committee, my name is Michelle Ate. I am co-chair of the Minnesota Pharmacy Association Public Affairs Committee, and I'm also a pharmacist for Walgreens. I wanted to bring to point that the issues presented today by all of my colleagues earlier affect all community pharmacists, from independent pharmacists such as Steve Simonson to myself, a pharmacist with Walgreens. It's important to remember that pharmacists provide a lot of valuable clinical services for our patients, such as medication therapy management and immunizations and health testing, but we also provide a product to our patient. And 76% of the product that we provide to our patients is generic. And as Dr. Schondelmeyer illustrated earlier, pharmacists need to have access to transparency and access to MAC pricing. Another important component of the bill that I wanted to address is that it allows our patients a choice. Patients should have a choice when it comes to where they get their prescriptions filled. Pharmacists are a valuable part of the healthcare team, and mandatory mail creates a fragmentation of care and cuts a patient's access to their local community pharmacist. Again, it's important that patients have a choice when they want to see their community pharmacist. There's a proven value in the power of a face-to-face interaction between a pharmacist and their patient. And the pharmacist also needs access to that patient's information so we can scan for drug-drug interactions and appropriateness of therapy. We support the testimony provided by my colleagues. It's important to realize that this issue not only affects independent pharmacies, but large retail chains as well, and I urge you to support House File 1872. Madam Chair, members of the committee, I thank you for the opportunity to testify here today, and I'd be happy to answer any questions.
All right, thank you very much. All right, I'm not seeing any questions, so I think we can go on to the next testifier. Thank you. And so we've got Dave Diedrichs, Andy Brem, and David Root. If any of them are present, please come down.
There's three.
Welcome to the committee. Who's going first here?
I guess they'll let the guy in the middle do it first, and then
Okay.
they'll sort it out on the ends. Thank you. David Root with Prime Therapeutics. We are a pharmacy benefit manager who is based and operates in the state of Minnesota. We have two facilities here and employ about 2,000 people in the state. Our primary client is Minnesota Blue Cross Blue Shield. I'd like to take just a moment to talk a little bit about sort of some of the implications for the various aspects of the bill and to talk a little bit about what a PBM does. PBMs are hired by health plans, employers, labor unions, large and small employers, and state governments and municipal governments also to manage the drug portion of a health care benefit. And we do that based on the contract that the employer, the plan sponsor, the payer of the benefit constructs. So we help them create the networks, we help them create formularies, and we help them adjudicate the individual retail claims. One of the things that we heard earlier today is that this measure, there are aspects of this measure that actually have no cost impact to the benefit design. Specifically speaking to the MAC pricing section of the bill, every time you take a drug off of a MAC list, that presents a situation where the drug is purchased by the retail pharmacy at a wholesale price, and if it is not subject to the MAC list, that means that the drug is reimbursed to the pharmacy at a retail price. And there's a difference there. So that means that they're able to purchase the drug at a lower cost and then be reimbursed by the plan sponsor at a higher cost. The language that we see in this particular iteration of the bill, based on our evaluation of the bill, would take 153 drugs off the MAC list that do not have an A rating, and 174 drugs would come off the MAC list because they do not have 3 or more generic manufacturers currently in existence. Accounting for overlap, that would be 294, if you take away the overlapping drugs, that would be 294 drugs that would come off the list, and that would represent approximately $3.2 million to additional costs to the plan sponsors. And remember, the plan sponsors, that money comes from their members who are constituents, people who run businesses, large employers who have employees, labor unions who have members, and government programs and government entities who have government employees. The other two sections of the bill, as we heard them described, dealing with data privacy and the mail order facilities and the specialty pharmacy. I'd like to take you back to the concept of the contract. We manage those contracts on behalf of the plan sponsors. The plan sponsors are actually very particular about what it is that they want. They set those parameters in the contract and expect us to adhere to those. The level of specificity around those contracts goes right down to the detail of how, if, and when we may correspond with their members. Some plans will say that you can never correspond with their members. Some plans will encourage you to correspond with their members, and others will say you can only do it after we've approved the particular correspondence in question. That is a contractual issue that has been solved and worked through and utilized in the marketplace as we go through, as PBMs have developed. I think it's interesting that we've heard that this is what needs to happen for plan sponsors to have transparency. Plan sponsors are not the people that are asking for these measures. They are more than able to account for those issues in their contracts. I think prefer it to be accounted for in their contracts so that we can be held accountable to those contracts as we all compete for that business. With respect to the mail order and the specialty pharmacy situation, that is very much the same situation. The plan sponsors will ask us to create networks to help drive lower costs and to create situations where they feel comfortable that their members are able to get the benefits they need and at a price that they can afford. Some of our plan sponsors will have very generous networks. Others will actually have very narrow networks. Each of those plan sponsors makes those decisions based on their ability to create a benefit design for their employees, what they can pay, what they can afford. We manage that program to those specifications. So we would encourage you not to impose a one-size-fits-all application and continue to allow the plan sponsors to maintain the flexibility and make us adhere to our contract requirements.
Okay. Thank you. Okay, question from Representative Zerwas.
Thank you, Madam Chair. Just if I could have you expand a little bit. You're talking about the MAC list and the list of drugs. Are these real oddball drugs that you don't see that often, or are they drugs that are commonly prescribed that could impact a lot of people where the price increases could hit a large portion of Minnesotans?
All right.
Mr. Root.
Thank you, Madam Chairman. First of all, just to be clear, these are, any drug that's on a MAC list is typically a generic drug, and these are drugs that are widely in circulation and are used, they're drugs that people have every day. Whether or not one of them is a drug that everybody in this room is taking or not, it runs the gamut. As what they are. What's important about them is the fact that we are able to create that pricing structure. One of the problems one of the issues behind generic pricing structure is when you have a brand drug, a manufactured brand drug, you have one person making that drug, they set the price. So everybody knows what that is, and it is what it is. When you have a generic drug manufacturing, you may have 4, 5, 6, 8, 9, 10 manufacturers making that drug. Each one of them will have a different price. We have a system where we survey that price in the marketplace, develop an average for that price, and then that average becomes our MAC price, becomes what we reimburse the pharmacies at. The point behind that is to encourage the pharmacies to be aggressive purchasers of those generic drugs. In other words, by aggressive, I mean to try to buy that drug at the lowest possible market price. That way, when they're reimbursed either at a break-even point or at a profit. One of the things that, and you bring up a very good point, and I'd like to take a moment to articulate this as well. One of the things that we hear is that MAC pricing is forcing pharmacies to lose money. I will not stand here today and tell you that a pharmacy will fill every drug off of a MAC list and make a profit. There are drugs on the MAC list that the pharmacy will fill and be reimbursed for at a loss. There's no question about that. However, the MAC list is designed as a total basket of care. Under that total basket of care, the pharmacy will receive a total profit for their reimbursements of generic drugs. On a particular drug, they may have lost revenue, be underwater, if you will. On another set of drugs, they may be above water by twice as much as what they lost, or equally, or thereabouts. And that range goes through the entire MAC list. Prime's MAC list is approximately 1,600 drugs.
Okay. All right, Representative Mack. Okay, Representative Abler.
Oh, thanks. Welcome back, Mr. Ritt. Nice to see you again. Just a few questions. I do contracting in my world, and the bigger the carrier with whom I contract, the less I have to offer about advice. If I want to change the word "the" in my Blue Cross contract, for instance, they say, well, nice having you as a thoughtful participant in our network, and call us back when you want to do business. And so that's why bills like this come to the legislature. We had this discussion a couple years ago, and there was some very good discussions. You mentioned $3.2 million on your 294 drugs on the list. Is that just for Minnesota?
Yes.
Okay, Madam Chair. And so what percentage of that do you think is pharmacists being underpaid and not getting their value out of that, where they're working below cost? Would that be all of that, or a part of that, do you think?
Mr. Root.
Thank you, Madam Chair. I'm not quite sure I understand the question, but I can tell you that we, in an attempt to get at it, and if I fail to get at it, please come back at me. We ran some numbers based on a specific group of pharmacies in Minnesota, and found that our total reimbursement for those pharmacies in Minnesota, compared to the pricing numbers that they reported to CMS, that particular group of pharmacies came in at a 29.1% profit. They made a profit of 29.1% off of their MAC list reimbursements compared to the self-reported pricing data that they reported themselves to CMS.
Okay, so
Representative Abler.
and we're not going to try to digest the entire world you live in or our stuff here, but my opinion is that part of that $3.2 million that you would have to spend to right size the list according to the bill, pricing wise, is actually the underwater drugs that pharmacists are having to absorb. And it may well be that some have a different basket of drugs, and some are actually losing more money than others. And as a lot of these are small businesses, some are large. But if they have to work below cost, it's hard to do business. And it'd be interesting to know, for later follow-up, what you got about that. Madam Chair, a couple more questions.
Okay, and Representative Abler, I'll let you do that, but we got these other two that want to testify, and I
got it.
kind of need to move through this, but go ahead.
But these are all to the key, but there's like 4 or 5 elements of the bill.
Okay.
On the correspondence thing, and I can see it's easy for the plan sponsor to say, well, you can never talk to your vendors. But there's testimony that if they want to appeal some of these prices, that there's an option you have within your system, an appeal option. Apparently one of the options is you can fax or mail a letter, and it may take a month to get the information back, and the appeal time is 30 days, and so there really is no appeal. Can you comment on that?
Mr. Root?
Madam Chair, I'm confused. Are you talking about an appeal on a MAC price or an appeal on some sort of communication to a member?
Representative Abler?
I believe it's the MAC price.
Okay, Mr. Root?
Thank you, Madam Chairman. Prime Therapeutics has and has had a web portal that allows any pharmacy in the network to review our MAC pricing for any particular drug that day. So it's real time. It's actually accurate. The appeal process in place for Prime, we ask the pharmacy to provide us with their cost for the particular drug in question, and we go back to our research for that particular drug on the MAC list to determine why the price is at one point from the pharmacy and why it is set at another point, if there's a difference at what our point is at the MAC price. If we find that it's simply a matter of the fact that many pharmacies are contracted with specific PSAOs or wholesalers, In those contracts, those pharmacies have purchasing percentages that they must receive. 40%, 50%, upwards of 70% of their drugs need to be purchased from that particular provider, from that particular wholesaler. If, in fact, that wholesaler happens to be the more expensive wholesaler in the marketplace, then we would likely, under those circumstances, if there were no other shortages in the marketplace that we saw, we would likely deny that appeal, simply because we would say there are other wholesalers in the marketplace where you can purchase that drug from at a cheaper price, at or below our MAC price.
Representative Abe.
Madam Chair, I wish I had more time to ask questions, but let me just help the three men at the table. The people are bringing this bill forward because they don't believe all your answers you just said. And so I am really happy that you're here doing business. I'm happy. I understand the world of PBMs. I understand the world of squeezing costs. I understand the world of margins and cost effect and all of that. But I also understand the world of providers, and they actually have to stay open. And so I don't know which company it is that's not responding timely, but somebody's not. And I don't know how we think people should work below cost. And so my advice to you all as this moves forward, and I'm going to vote for it today, I'm a co-author, is that you look at each section and look at the problem that they're trying to bring forward and see which of those you can accommodate. But if the answer, Madam Chair, is that some plan sponsor doesn't want to have any discussions with the vendor, that's ridiculous. Just because, I mean, that, and which is kind of different than what you said about your particular policy about these appeals. But Minnesota's a really great state. We have really good pharmacies and doctors, and we do it. It's all kind of a fair playing field. And just because some company doesn't feel like allowing a person to have a question or wants to make some small company have to go to a new vendor they don't even have contact with to avoid going out of business doesn't make sense to me. So I'm here to be part of the solution. I'm really happy you've all come forward with the witnesses and the three there, and I'll probably sit quietly the rest of the day, but thank you very much, Madam Chair.
All right, thank you, Representative Babler. And Representative Mack has a question, but should we let the other two finish first, or do you want to?
No,
first?
you can finish first.
Okay, let's let the other two testifiers have a word in here, and then we'll ask a few more questions before we finish up.
Thank you, Madam Chair and members. My name is Dave Dieterichs, and I work with Express Scripts. Appreciate the opportunity to be here today testifying in opposition to this bill. Express Scripts, too, is a pharmacy benefits manager. While we're headquartered in St. Louis, Missouri, we have a large facility in Bloomington, Minnesota, where we employ 1,600 people. We administer the prescription drug benefit portion of plan sponsors' insurance, just like David had talked about earlier, but we do that for 100 million Americans. So labor unions, government entities, health plans, and Fortune 500 companies all carve out the prescription drug benefit portion of their health insurance and contract with companies like mine to administer that benefit to their beneficiaries. We have numerous clients in this state that cover the spectrum of labor to health plans to government entities, and we provide integrated pharmacy benefit management services to all of them. One of the cornerstones to our industry and our business in particular is utilizing generic drugs. So when a brand name drug manufacturer loses patent protection on one of their drugs, oftentimes blockbuster drugs, we see the introduction of generics into the marketplace, which oftentimes, within the first 30 days, take 90% of the market share of these blockbuster drugs. Generics, as we all know, cost about a third on average of what the blockbuster drugs do. So there is a significant savings opportunity. It's how market competition is supposed to work. We also offer mail order pharmacy services. We negotiate discounts from brand manufacturers. Again, because of our size, we have significant scale, and we can get big discounts to help our members with cost savings. Our company's mission is to make prescription drugs safer and more affordable, and we cannot do so unless we align our values with our clients, and that is to save them money. And so in order to make money as a company, we need to show them savings. And these are some of the ways that we do that. We create networks of retail pharmacies. We perform drug utilization reviews to prevent adverse drug interactions within patients. And we operate specialty pharmacies, particularly with complex disease states. Joining me today is Andy Boehm. He's our chief pharmacist. We have 3,000 pharmacists that work for our company. Andy's our chief. He heads our specialty formulary committee as well as our normal pharmacy and therapeutics committee. He's going to talk a lot about plan design as well as quality and accessibility, which I know this being the policy committee is particularly important to your jurisdiction. There's been a lot of talk about MAC today, so I'm not going to go through the details of how MAC is determined. I think you have a pretty decent idea about that. But there are two particular portions of the MAC legislation, or the MAC section of this legislation, that I want to call to your attention. And this is on lines 2.33 through lines 3.2. As I mentioned earlier, when a brand name drug loses patent protection, generics often come into the marketplace. Oftentimes, the first 6 months after a brand name loses its patent protection, a specific generic drug is granted an exclusivity period of 6 months where they can market that drug. And then after those 6 months, oftentimes more generics come into the marketplace. According to this legislation, you're not allowed to MAC that generic drug during that 6-month period of exclusivity. So, while the savings are there to be had with the generic drug, it cannot be MAC'd. And so, again, as David mentioned, a pharmacy will purchase that drug at a wholesale or a retail price, but it will be reimbursed at a brand price, and that spread difference between those two costs is going to be picked up by plan sponsors and ultimately beneficiaries. Second, in this portion of the legislation, it says that a drug can only be MAC'd if it has 3 or more nationally available and therapeutically equivalent drugs. Okay, and earlier in the definitional section, it says therapeutically equivalently means 3 A-rated drugs. Now, the FDA has different ways of grading what generic drugs are. They have A ratings, they have B ratings, they have Z ratings, they have NR ratings, they have NA ratings, and sometimes they don't rate them at all. A lot of times, generic drugs don't have 3 A-rated drugs in their category. So every time you have a generic drug that doesn't have 3 A-rated, it can no longer be MAC'd and is subject to brand pricing and therefore brand reimbursement. The same thing happens with drugs that have no rating at all. In fact, I contacted our supply chain yesterday to talk to them about this specific provision. We have 2,058 orphan generic drugs. That means these generic drugs exist in the marketplace without other generic competitors. They are single-source drugs, and they no longer are going to be available to MAC pricing because of legislation, or this portion of the legislation. So again, those 2,058 drugs are no longer going to be available at the wholesale or retail price. They're going to cost at the brand or retail price that pharmacies charge. Again, that spread is going to be passed on to consumers. I further passed along this legislation to other members of our supply chain who negotiate our drug discounts. And they said that using our master formulary, if they took this legislation and applied it to it, they said that every plan sponsor in the country that uses us could anticipate a 6% increase in their overall total drug spend from last year. 6%, just because you can no longer take advantage of those generic opportunities. David talked a little bit about mail. It was mentioned by the previous testifier, so I just want to touch on that for a moment. Mail order pharmacy services are important, and they are for several reasons. Again, it's all plan design. We don't mandate that anybody use our mail order pharmacy services. If a labor union wants to use our mail order pharmacy services, they can design their benefit that way, and subsequently we will administer it. The reason why mail order is important is because you can get a 90-day supply of drugs sent to your house for 2 copayments. Because of our scale and purchasing power, we can eliminate an entire copayment for an individual as well as an entire copayment or payment by a plan sponsor every time mail is utilized. Now, this legislation doesn't say that you can't use mail order pharmacy. What it says is that if a retail pharmacy agrees to the same terms and conditions that are applied to a mail order pharmacy, then they can do so. But here's the problem with that. Mail order pharmacy is safer. A good retail pharmacy will dispense with about a 98% accuracy rate, maybe a little north of that, which means approximately 2 out of every 100 patients is going to walk away with the incorrect prescription. Our mail order pharmacy makes 2 errors per 1 million transactions. As soon as that drug leaves, or before the drug leaves our mail order pharmacy, over 150 safety checks have occurred, including multiple built-in redundancies to make sure that the right drug is going to the right individual in the right amount. We try to incent our plans to utilize mail-order pharmacy services because we've also found, and this is pertinent again to this committee, that patient adherence to mail-order pharmacy services with their 90-day supply of drugs is better. which means they're adhering to their regimen of medication, and they're not skipping days because they were unable to get to their local pharmacy at the end of the month because they had to be at a hearing at 6 o'clock for medical marijuana or for some other reason. So we see that there is a positive adherence. They also see that it's safer and it's also more affordable. So we encourage the use of mail-order pharmacy services. And finally, as regard to the any willing pharmacy services, you heard the proponent testifiers state that it's important that anybody should be able to go anywhere they want to get their drugs. Well, I can tell you that there are 69,000 pharmacies in this country. Just to give you an idea what that number is, if you were to take all the McDonald's in this country and all the Starbucks in this country and add them together and then triple it, that's still not the number of pharmacies that we have in this country. There is sufficient access to pharmacies everywhere. Of those 69,000, my company contracts with 65,000 of them. In Minnesota, it's over 1,300 that we contract with, and we have appropriate geo-access and safety requirements built in. Honestly, there are certain pharmacies that we don't want to contract with, whether it's fraudulent activity, wasteful activity, or abuseful activity. Sometimes there are pharmacies that it is just not necessary for them to be in our network. Also, if we limit the number of pharmacies that participate in our network, oftentimes for our plan sponsors, we can save them money because we can drive down reimbursement amounts in return for guaranteed increased foot traffic. So with all of that, Madam Chair and members, I apologize for being so long-winded. I'll end my comments.
Okay, thank you. And Mr. Brame, I'm going to give you a few minutes, but we're going to need to wrap it up pretty quickly, and members do have some questions, so go ahead.
Absolutely. I'll keep it short and sweet. My name is Andy Baim, for the record.
Sorry?
It's B-A-E-H-M. I work at Express Scripts, and I'm the Vice President of our Office of Clinical Evaluation and Policy, and as Dave mentioned, known by Dave and maybe a small number of other folks, but now I guess to this wide group of people as our Chief Pharmacist, so I'll take it for this session at least. I am a pharmacist and a certified geriatric practitioner. I'm also a graduate of the University of Minnesota, and I completed my residency at the Minneapolis VA, and I'm also a member of the Minnesota Pharmacists Association. Today I'm just going to be focusing my comments on the specialty drug section. Really briefly, a specialty medication. There are widely varying definitions of specialty drugs, but in a nutshell, specialty medications tend to be medicines that are targeted at very unique and complex diseases and conditions. Some examples may be cancer, multiple sclerosis, rheumatoid arthritis, and hepatitis C. They tend to be conditions that require a lot of patient counseling, and they might be very complex regimens and challenging to treat patients with. We define medicines as specialty, and we have an extensive group of clinicians that support specialty medicines through our facilities. At this point in time, we have over 500 pharmacists who are trained in these specialty, very unique disease states. Many of them have come from tertiary care centers. They've come from the University of Minnesota. They're experts who have treated and managed patients with these very unique conditions. In addition, we have 600 nurses that not only counsel and work with patients directly, but particularly during the first fill or two, many of these medications are infusible products, very challenging medications for patients to take. Our nurses will fly out and meet and spend time with those patients in their homes and spend time and really counsel them on how to administer and apply those in a setting that those patients are comfortable with. So a wide range of clinicians. I just want you to understand that, because as a PBM or you hear Express Scripts, there's an assumption that it's just a business. It's absent clinicians. As Dave suggested, we have over 3,000 pharmacists, and a large number. This is our clinical hub here in the Twin Cities. Great. So we define medications as specialty, so what? All of that expertise that we have in place allows us to generate better outcomes. When we look at the outcomes provided by our specialty pharmacies, we typically see adherence rates that are 10 to 20% higher when compared to retail settings, and in fact when compared to other specialty vendors. We also see reductions in emergency room visits. We track those in studies. We publish a lot of our information in peer-reviewed journals, and that generates overall lower costs for plan sponsors. They save on the medical side when patients are taking their medications as intended and seeing better outcomes. That's important because I think as my colleagues have alluded to, our plan sponsors are sophisticated purchasers. They don't just take my word for it. I don't just come there and say, we're doing this in a better way. They demand the outcomes. And getting to the provisions around specialty pharmacy, those plan sponsors will demand, show me the proof that you can do this better, and then maybe I'll consider limiting the number of providers that are providing that service. At the same time, too, as has been alluded to, there are many plan sponsors that say, hey, I'm providing a benefit. I want everybody to access it in any way they want to possibly. So it's really the plan sponsor that's dictating the terms, and we're providing a suite or a menu of solutions. And we think we've got a very good one for them to select from. I could go on, but I know you wanted me to be brief, and hopefully that's enough.
Okay, I've got a couple of members, 3 members. Representative Mack.
Thank you, Madam Chair. And just a couple of brief questions, and whoever wants to answer is fine. I guess one, if you could just respond, I'm trying to get a handle on, in the prior testimony from the pharmacist, they kind of referred to this term, or the MAC pricing, hidden prices or a hidden market, and when they're informed of what that price is going to be so they can adjust properly. If you could just speak a little bit to that process, and if that's a fair character of what's going on there. I'm just trying to get a handle on the transparency within the MAC pricing and how the pharmacists can maneuver within that to make their business model work. And then my second question is on the public program side. I'm just wondering if, I think you said Express Scripts also maybe does some government contracts, I thought I maybe heard. But if not, I'm just wondering if in the MA Minnesota Care, if a lot of this stuff is already adhered to and therefore needs to be carved out of this bill because it just doesn't apply.
Okay, could we just get maybe one of you responding?
Okay, go ahead. Sure.
And which one would like to do that? Mr. Root?
Sure, I'll take a crack at it, Madam Chairman. I alluded earlier to, I mentioned the concept of the web portal Prime Therapeutics uses. That's an opportunity for any pharmacy in the network to go online and use their super double secret password, get in and be able to look up the drugs and determine what the MAC reimbursement rate is that particular day. It's important to remember that the MAC reimbursement, the amount of that reimbursement is subject to change. It is fairly volatile as manufacturers and other situations happen in the marketplace. But they are able to get that price. They are also able to get that price if they were to run a claim, a dummy claim, and then they would see what their reimbursement is. When a pharmacy transmits the fill to the PBM, part of the information they get back is what they're going to be paid. So while they're filling that prescription, they know what they're going to get paid for the reimbursement on that particular drug. As far as the plan sponsor, I think, because your question, I think, had two parts. The plan sponsors are fully cognizant of what our MAC rate is and what our reimbursement rate is and our reimbursement philosophy is as far as the pharmacies are concerned. That's not, as it was alluded to, a hidden spread. They're well aware of that. In fact, that often is one of the reasons why a particular PBM will or will not win a specific contract.
And we're frequently audited by our clients. I mean, they are very sophisticated
Yeah,
purchasers.
and we have to go through the chair here, so you can't just start speaking because it's being recorded.
I
so
apologize.
That's Mr. Diedrichs.
Yes, I apologize, Madam Chair, members. I was saying that our clients are very sophisticated purchasers who have built in very thorough audit rights into their contracts. And oftentimes, items like this is a reason why we either retain or lose business. And so they do have access to all of that. None of this is hidden. None of this is transparent. Express Scripts, too, has a web portal or a phone number that a pharmacist can call and access that information any day of the week. I checked with my supply chain. Last year, there were 508 MAC appeals in Minnesota out of 9.8 million claims, which comes to a whopping 5/1,000ths of 1%. And so we do try to give this information to the pharmacists as they're going forward.
Okay, and I didn't hear an answer to the question about the public programs.
Madam Chair, we believe that they are excluded because, as we articulated here today, specifically around the MAC section of the language, it would be a cost driver because it would exclude, if public programs were not excluded from the measure, it would exclude certain drugs from being MAC'd, thereby have a cost implication to the program itself.
Okay, Representative Albright.
Thank you, Madam Chair. This could be either answered by Mr. Root or Mr. Diedrich, but I'm just wondering, and this may be a rhetorical question, but I'll ask it anyway, is every one of your clients' agreements with you negotiated?
Madam Chair and Representative, are you talking about our plan sponsors, the health insurers, the
Every
government
client you
entities, labor unions? Yes, they are. And they are very aggressively bidded for every 3 years. That's the average length of our contract.
Okay.
Madam Chair? And so, by implication, you have a willing buyer and a willing seller.
Mr. Diedrich.
Madam Chair, yes, that's correct.
So you're...
Representative Albright.
Thank you, Madam Chair. So literally, you have a contract that would include in it such provisions as for transparency, for breach of contract, enforceability issues for misconduct, malfeasance, misappropriation, misconduct, just as any contract durable in the state of Minnesota could be enforceable under a civil action, correct?
Madam Chair, yes, Representative, that is correct.
Madam Chair,
Okay.
I just have one question.
Okay. Well, we don't have a lot of time for rhetorical questions, though, Representative Albright. Okay. Go ahead. Last one, because we've got a couple other members that want to ask a question, and we're going to cut this off very soon.
So is there a lack of transparency to any of the contracts that you foresee in the future?
Madam Chair, Representative, the answer is no. And in fact, if there is other forms of transparency that a plan sponsor or bidder wants in their contract, there are over 40 PBMs in the marketplace that will very aggressively bid for that business. And whatever terms the contract sponsor or the plan sponsor wants included in their contract, they'll get.
Okay. Representative Gruenhagen.
Oh, thank you, Madam Chair. Just my question has to do with, I can see, based on Representative Abler's comments, in a small rural area, it's hard for an independent pharmacist with a lower volume to stay in business nowadays. And yet, on the other hand, I don't want to do anything to drive up the cost of drugs for poor people or people on fixed incomes, which a lot of retirement people are on. I've sold health insurance for about 35 years. Representative Atkins trying to put me out of business with the MNsure, but I'm still sticking in it. I'll try and return the favor sometime for lawyers. I know we're running out of time. So what would be your solution? If this isn't the right fix, what would be your solution to help those independent druggists, especially in the rural area, where people need access, to allow them to make enough profit to stay in business in those areas? Because I see the pharmacy branches shrinking, not expanding, and the bigger ones keep taking more and more of the customer, giving a better price, which I appreciate, but it is a problem in those those sparsely populated areas in the state of Minnesota. Do you have a solution if this isn't the right bill?
Mr. Diedrich?
Madam Chair, Representative, that's a great question, and I think you did identify the source of the problem in your question itself. And it's not PBMs that are causing the problems for the independent pharmacies. It's the big box retailers that are moving into their community. They have more purchasing power. They have larger scale, so they can offer better deals and better discounts. But to let you know, it is those small rural independent pharmacies that are most valuable to our network. We have geo-access requirements imposed upon us by CMS as well as by our plan sponsors. And so those pharmacies, absolutely, they're going to be in our network. It's going to be in the it's going to be in the urban centers or the cities where you've got 4 pharmacies on every street corner. Those are the ones where we're going to be more selective.
Okay. All right, Representative Huntley. I've got Huntley, then France, and then Schoen.
Madam Chair, and this relates just to the mail order sales. And how do you address my concern, which is with healthcare homes, where there's a connection between the pharmacist and the purchaser? And often the pharmacist knows more about drugs than the physician that wrote the prescription. and can advise that patient, or that, in this case, customer. If you have mail orders, that seems to me that's fine.
Who is that question for?
Madam Chair, Representative Huntley, thanks for the question. I think first it's important to note that we don't mandate mail order on anyone. It is the plan sponsor that sometimes designs their benefit that way. But specifically to your question, most plans are set up so that a person can have either the choice of mail or continuing to go to the retail pharmacy. But I do want to note that we have pharmacists that are staffed and on the phone 24 hours a day, 7 days a week, 365 days a week of the year, and you can contact them from the privacy and safety of your own home instead of having the person 3 feet behind you at the counter listening to about the rash that you're going to get from the drugs you're about to take. And so we do try to provide that patient care and access. And just as Andy said, we have the doctors and the nurses available as well.
Okay.
Thank you.
All right. Representative Franson.
Thank you, Madam Chair. And in respect of time, I won't ask all 6 questions I've got. So, to the testifiers, objections to Section 2 of the bill center around the idea that the bill prevents PBMs from using MAC pricing on certain drugs and would result in higher costs for plan sponsors and higher profits for pharmacies. Pharmacies say they have no intent to raise costs, but simply want to make sure the MAC prices are only used when appropriate. My question to you is, are you willing to get together with the proponents of the bill and work out a resolution to your differences in this area?
We'd be glad to talk to them.
Mr. Root.
Madam Chairman, we'd be glad to talk to them. They have, as yet, not approached us and did not approach us prior to dropping this bill.
Representative Franson.
Thank you, Madam Chair. I'm under another impression that they have tried to talk to you. When do you foresee a meeting taking place?
Mr. Root.
Madam Chair, it was my understanding that the patron of the bill had requested that we all get into a room on the 11th.
Okay.
Excuse me.
Okay, great.
Right.
And then my next question is, Madam Chair.
Right, but Representative
One more.
Franson, if you're just reading some questions from somebody else, can you kind
Well,
of
I
focus
typed
in?
them up.
Okay, well, we don't have a lot of time here. And let me just say, members, since we're discussing this, if we don't finish up after we hear medical marijuana tonight at 6, I mean, it's really what members want to do, but we've got 2 other bills on the agenda. After we finish medical marijuana, we will complete our agenda. So it all depends on how long people want to stay tonight. Go ahead, Representative Francis.
Well, Madam Chair, would it be better if I'd handwrite my questions out then?
You go ahead and ask them.
I just got one more.
Okay.
Do you, to the testifiers, by any chance, do you happen to mail or own the mail order in specialty pharmacies that fill the prescriptions for your plans? And if so, how does that impact our rural pharmacies?
That's a great question, Madam Chair. And Representative, thanks for asking. We do at Express Scripts own both a mail order pharmacy as well as specialty pharmacies. But it should be noted that in terms of specialty pharmacies, it's oftentimes the FDA as well as the drug manufacturers that have certain REMS or risk evaluation mitigation strategies attached to these complex drugs that require limited distribution channels. And therefore, because of our expertise and specialty, they oftentimes contract with us. Now, in terms of mail, we adjudicated 1.4 billion prescriptions last year. And despite our best efforts, we cannot break the 10% mark of mail order pharmacy services. 1.26 billion of our transactions were adjudicated at the retail level, which is why we contract with so many pharmacies, because they're invaluable business partners of ours.
Representative Franson? Okay. I really don't want to cut you off. I'm just trying to kind of focus this here because we have other business to do. And Representative Schoen?
Madam Chair, probably my question to any of you. So tomorrow we enact this, and I go to get the drugs I need at my local pharmacist. What's going to change for me?
Mr. Root.
Madam Chair, specifically for the consumer, at this point, you would not find, for most of this, you would not find an impact at your pocketbook until your insurance reevaluation, and your insurance reevaluation has to account for these losses. If that drug was a drug that was on your currently, prior to passage, on your maintenance list for your plan and then thereby requested to get it mail, you could be, after the bill passes, you could be paying 3 copays as opposed to the 1 or 2 copays you were paying at mail. Because what happens, as I understand the language for the mail particular section, is that we have to have leveling. There can be no incentivizing. So we would, it's possible that a plan would require us to move everything to 3 copays because you get a 90-day supply, so that's 3 months. So you'd pay 3 copays, 3 fills, which would be perhaps what you're not doing now.
Representative Schoen?
Thank you, Madam Chair. Well, I do have to take exception with one thing said about having 4 pharmacies on every corner and how accessible it is, because I've had more than one constituent, actually several, call me with complaints about this issue that they can't go to their pharmacy. And in my district, to weave your way up to the next pharmacy that would be accessible is not exactly easy. It's not driving from Chisholm to Duluth by any means, but it's still not overly accessible, so I do take exception with that. Being able to get the drug you want at the pharmacy you want is a big deal, and this is thank you, Chair Atkins.
Okay. All right. Thank you, gentlemen. Let's have Representative Atkins come back, and if you want to wrap up and say a final few words, and then hopefully we can get to a vote on the bill and move on. So, thank you.
Thank you, Madam Chair and members. As I said at the outset, that's why I wanted to keep my remarks short at the beginning. I promise you no more than 2 minutes here at the end. I do want to thank everybody for this has been a very thoughtful hearing, good testimony on both sides. I want to thank Representative Abler and Morgan, as well as Representative Davids, for authoring this bill with me. Just a handful of points that I think they're making. First off, with respect to drug price transparency, if, as Mr. Diedrich said, this information is already so readily available, I'm curious why they're opposing it. All we're looking for is a stating of the price. Everywhere else, every other market on the planet, now I'm just a simple fellow from Inver Grove over here, but every other market, when you state the price, you go to the grocery store, for heaven's sakes. If you don't have any price tags, right, on the food and all of the various things that are in there, and you go up to the checkout counter, and it's just a surprise at how much it's all going to cost. All this is doing is putting those price tags on so folks know what they're getting when they go and they check out. And you can do, when you have those price tags exposed and people know what the prices are, it tends to drive down the price, not drive up the price. Now, I know that's Commerce Committee, Madam Chair, so I'm going to get back here to the health stuff. But I just wanted, there was a lot of talk about pricing, and that's what happens when you make the price transparent. The second point, they're just simply talking about patient choice in this bill. You give patients a chance to keep their own pharmacist. For some folks, they might be perfectly comfortable getting it in the mail. For others, it really does help to have that relationship with that local pharmacist, a real human being that you can talk to in person, even if they do have to tell you about the rash this might give you. It's just there's some people for whom that's a very comforting feeling to have that local pharmacist there to walk through with them what it's good for their health. And that's only, by the way, if they're willing to sell it at the PBM's price. We're not trying to drive up the price, and as Dr. Schoenemeyer said, if anything, as the grocery store example, it brings down the price, 5, 10, 15%, whatever it happens. We'll talk about that more in the Commerce Committee. But final point, and that is about patients' data privacy. We went over that fairly quickly, but what this requires at the end is that you keep your private data private. It can't be given away, it can't be sold, it can't be, for various marketing purposes, given off to certain pharmacies, and that's what we're trying to protect against. In some, Madam Chair, Minnesota's consumers actually have better protections at body shops when they get their car fixed than they have with respect to prescription and other drugs they get from their pharmacy right now. So when we make some simple comparisons, that's the comparison. I think that people deserve in Minnesota the same sort of protections they have when they get their car fixed as they do when they do something as important as getting their prescription drugs. I appreciate the chance for hearing, and I appreciate your support.
Thank you, Representative Atkins. And, of course, there's a lot of overlap here between commerce and health, and that's why we're here. And of course, the price of pharmaceuticals is very important to this committee because it means access and people being able to buy the drugs that their provider prescribes for them, which of course is very much about health, and of course the impact on the small pharmacists where people can go and get the advice they need as well. So a lot of overlap there, and thank you for bringing the bill. So are there other questions from members? I don't want to rush us too much, but I think it looks like the committee is ready to vote. So Representative Abler will renew his motion that House File 1872, as amended, be re-referred to the Committee on Commerce. All those in favor, please say aye.
Aye.
All opposed, no?
No.
The motion prevails. Thank you.
Thank you, Madam Chair and members.
Okay, well, we have about 5 minutes here. So let's take up So we'll take up House File 2545.
I voted yes. Okay. No, that's fine. Let's vote. Okay.
I don't think my concern about that. Only 10% of the drugs usually don't.
So we're taking up the easy ones. We can hopefully get through it.
These are easy.
Yeah. It's the easy stuff. Okay. But I'm going to probably get you know, because I'm not totally in the weeds on this one.
Representative Liebling, would you like to...
All right. Could we ask the audience to please quiet down so we can proceed?
Thank you,
If
audience.
you're leaving, please leave quietly.
Thank you. Okay, Representative Liebling, would you like to move your bill?
Yes, thank you, Madam Chair. And this one, so I would like to move House File 2545, and we're going to lay this over for, Civil Law. Okay, so we'll move that this be re-referred to the Civil Law Committee.
Thank you. Go ahead.
Thank you, Madam Chair and members. So members, hopefully this one is a little less contentious. This is the Board of Pharmacy's policy bill for the year, and it has a lot of updates to some work that we did last year, some of it related to changes that have been made at the federal level. And I'm going to let Dr. Weiberg walk you through the bill. Hopefully quickly, maybe we can do this before we need to adjourn, but if not, we'll come back and vote on it later. But I don't think there's a lot that should give people heartburn, but I'm going to, and you have this pharmacy issue brief that should be helpful that's in your packets as well. So, Dr. Weiberg.
Madam Chair, members of the committee, I'm Dr. Cody Weiberg. I'm the Executive Director of the Minnesota Board of Pharmacy, the state agency that regulates pharmacy practice and distribution of drugs in the state. I am not going to go section by section. Ms. Aves has, I've looked at her review of the bill. It is actually very detailed. I really just want to highlight 4 major portions, and I certainly would take questions on any section of the bill, but there are really 4 major things that the Board of Pharmacy is trying to do with this bill. The first has to do with compounding and manufacturing, and many of you may remember that last year the board was before the legislature to get legislation passed in the wake of a severe compounding crisis. Pharmacy out in New England shipped a contaminated product to pharmacies, or actually to clinics and hospitals across the country. Nearly 70 people died. Over 750 people were infected. 12 people in this state were infected. We worked with the legislature to get some requirements into law last year. And then Congress passed a federal law called the Drug Quality and Safety Act, and I actually did quite a bit of work with Senator Franken's office on that piece of legislation. So the compounding provisions that we are proposing in this legislation really are meant to align state law with the changes that were made by Congress last fall. And In essence, one of those changes goes directly towards the sort of facility and the sort of compounding that was implicated in this disaster, which is compounding of sterile products. So federally, there's going to be a new class of facilities that are called outsourcing facilities. They have the option of being registered by the Food and Drug Administration and inspected by the Food and Drug Administration. Our language simply says if they choose to be registered by the FDA, they also have to be licensed by the board. That's consistent with the long-standing statutes that we've had that require any company that ship into the state of Minnesota, ship drugs into the state of Minnesota, to be licensed by the board. It also creates a safe harbor for pharmacies and practitioners, like physicians that want to do compounding, says that they in fact can do compounding without being licensed as a manufacturer, as long as they don't engage in certain types of compounding activities which would be prohibited under federal law. So that's issue number one. The second issue has to do with synthetic designer drugs. These are street drugs that are sold often as being herbal incense or plant food or research chemicals. They're actually drugs. And they are meant to either mimic stimulants or hallucinogens or cannabinoids, marijuana-type substances. The board has been working on this issue extensively for the last several years because we're the agency that in between sessions can add substances to the schedules through the rulemaking process. We've also worked with legislators on a bipartisan basis to make changes to the schedules that are found in the statutes. In addition to that, we have worked to on what's called analog law or an analog provision, but all of these provisions have not been sufficient to entirely shut down the companies that are trying to sell this, the head shops and that sort of thing. So the Speaker appointed a select committee on controlled substances and synthetic drugs. The Attorney General has worked on this. We've worked with both the select committee and the Attorney General's office. We have language that was proposed by the Attorney General's office that the board supports that would give the Board of Pharmacy what's known as cease and desist authority. It would make a change to the definition of drugs to make it crystal clear that these products are drugs. If they're drugs, then they are misbranded, meaning mislabeled, and they're adulterated under state law. The board could then issue a cease and desist authority and tell these shops to stop selling the drugs. The third issue involves pharmacist immunizations. And pharmacists have been allowed to immunize for over a decade, but until the large chains started having all their pharmacists do that 3 or 4 years ago, actually not many pharmacists immunized. Now they're immunizing in a big way, and even though the vast majority of pharmacists do an excellent job, there are some out there that haven't. And the health department and the board have noticed some problems, so the health department and the board have worked together on some language that would strengthen the requirements pharmacists have to follow when they immunize. The final thing really is a major issue is we are proposing to completely rewrite those portions of the Pharmacy Practice Act that deal with disciplinary actions that the board can take against licensees and registrants. This kind of fits in with the unsession theme, I think, because in doing research I found out that our grounds for discipline mostly date back to 1941. And there have been no changes to our disciplinary sections in over a decade. And our assistant AG has consistently recommended over the last couple of years that we update our disciplinary language and bring it into this millennium. And so those are the 4 major issues. I certainly can take questions on any sections of the bill.
Representative Albright.
Thank you, Madam Chair. And this would be regarding subdivision 36. And in particular, I have a question from a constituent who is in the ophthalmological surgery industry for eyes.
Representative Albright, I'm sorry, Madam Chair. If Representative Albright, could you give us a line and page if you
9.7.
9.7?
Okay, continue, Representative Albright.
Thank you, Madam Chair. My understanding about some of the compounds that are necessary for providing relief from certain ophthalmological conditions, there are two drugs. One that is sold in a much larger amount, but in terms of the frequency with which patients come in and need a shot, they can't assign it to that individual patient, but yet it comes in larger amounts, and so they're drawing it from a larger vial. Would the eye clinic be considered compounding that, or would it be considered distribution or bring it down to smaller quantities? Would this anticipatory, because it is a compound coming from another destination, would that type of a circumstance fall under subdivision 36?
Dr. Weiber.
Madam Chair, Representative Albright, yes, it would. In fact, I probably talked to the constituent you're talking about just the other day. We've certainly worked with the ophthalmologist extensively over the last year and a half. Some of the language that we have in this bill, as opposed to some language that we proposed last year that didn't move forward through the process, actually directly addresses the concerns that not only ophthalmologists have expressed to the board, but also, quite frankly, veterinarians. They're another type of practitioner that often need products very quickly, and they can't wait for a pharmacy to compound the products. And so the language here, actually that language and some other language, actually would allow ophthalmologists to do what's called anticipatory compounding. What they're talking about is a drug, I'm sure they're talking about a drug called Avastin, which they take from a manufactured source and repackage into smaller packages. It's actually not this language. There's some other language that basically says that manufacturing does not include the pre-packaging of a drug by a pharmacy or a practitioner, and that's what they would be doing. They'd be pre-packaging the drug and getting it prepared for subsequent administration.
Representative Albright.
Thank you. That completes it.
Okay, Representative Franson.
Thank you, Madam Chair. And to the testifier on subdivision 10, mental examination, access to medical data.
Dr. Weiber.
Line 22.8.
Okay. Yes.
Okay, I just have some reservations about that entire section. The first line says, if the board has probable cause, what would you consider probable cause?
Dr. Weiber.
Madam Chair, Representative Franson, the board gets about 150 complaints per year, and so we are, when it comes to issues like this, we're pretty much complaint-driven. We don't require, for example, licensees and registrants to undergo routine assessments or something like that. We actually get complaints, and I can't go through all specific details about some of these complaints, but we've had complaints about pharmacists while on duty displaying signs that would indicate some sort of significant mental illness process going on. So that sort of complaint would be essentially what our probable cause is. We would actually have, typically in a case like that, it might be a coworker or customers, or usually by the time we would do this, both. And so what we do in terms of discipline is largely complaint-driven. The only exception to that is, unlike some of the health licensing, or most of the other health licensing boards, we have our own inspectors or surveyors that go out and do inspections, so it might be possible, if this has happened too, although it's rare, where the inspector has gone in and a pharmacist was clearly having some issues.
Thank you. Representative Franson.
Thank you, Madam Chair. don't know how to word this. So what you're saying is anytime that there is a complaint made against the pharmacist, if there is a complaint made, and you could just go into their medical records at any time?
Well, Madam Chair, could I respond?
Representative Liebling.
Thank you. Representative Franson, probable cause is kind of a legal standard, and we could ask our staff to speak to that, but it's not. It's a lot higher than just there's any complaint. I think Dr. Weiberg is kind of giving an example, but probable cause, it's one of those terms that it is a little bit know it when you see it, but it's something that people that work with this kind of stuff are very accustomed to. So it's more than just any old complaint. It's sort of a complaint that really seems to have some validity to it. So it is a threshold that screens out just a lot of, disgruntled customer kind of complaints that wouldn't mean much. But I think it is, even though I know it's not real specific in the bill, that's kind of the nature of the beast, I would think. Maybe, I don't know if Dr. Weiberg agrees with me there.
Madam Chair, Representative Franson, that is true. And also, if you take a look at the language that you're questioning on line 2210, it talks about subdivision 2, clause 14. That's on 17.10. And so these are grounds for discipline, and it would be for a pharmacist, the inability to practice pharmacy with reasonable skill and safety to patients by reason of illness, drunkenness, use of drugs, narcotics, chemicals, so it's a very specific type of complaint. I'd also add that this language was modeled after the disciplinary language in the Board of Medical Practice Act. And so that particular board was actually reviewed by the legislative auditor a couple years ago for its disciplinary practices, and I think got a pretty clean bill of health, which is why I actually use that as a model for the language.
Thank you. Now, if members have any other questions, we're going to need to recess and come back this afternoon. Representative Franson, is any other questions? Well, I would like to move to a vote.
Okay, so I would renew my motion that House File 2545 be re-referred to the Committee on Civil Law, right?
Yes.
Civil Law.
Yeah. So all in favor, we say aye.
Aye.
All opposed? We are so moved. Bill passed. Okay, and we are in recess until 6 o'clock in this room. Thank you.